Hi, I'm Dr. Justin Linam. I'm a radiation oncologist here at Logan Health. So chemotherapy and radiation are synergistic. They work against cancer cells in different ways that are complementary. Chemotherapy, for example, is taken by mouth in the form of a pill or can be delivered intravenously. It goes throughout the body and attacks rapidly dividing cells, cancer cells, by damaging their DNA in certain ways depending on the chemotherapy agent. Radiation therapy consists of focal, very highly precise beams of high energy photons usually that also damage cancer cells' DNA, preferentially over normal cells that are nearby and not rapidly dividing. And the cancer cells that are damaged by chemotherapy are more sensitive to radiation damage, and vice versa. And so it's a synergism there, a synergy, and they work together, and we often use them together concurrently or at the same time when we're treating lung cancer. How we treat any cancer is really very highly dependent on a number of factors. The type of cancer that it is, the location of the cancer, some other aspects at times such as the grade or the measure of aggressiveness of the cancer. And we can use surgery, we can use chemotherapy, we can use radiation, we can use all three, we can use some together. And it all really comes down to scientific trials and what we've determined is the best way, the most successful way to treat a certain cancer in a certain clinical context. When we started radiation therapy, first of all, the first radiation treatment for cancer was in like 1896, okay, long time ago. And at first, and for many decades after, we didn't really have a lot of finesse with the radiation. It was sort of these big fire hydrants of radiation. There wasn't a lot of subtlety, it was sort of crude. But over time, through advances in physics and a lot of advances in radiation biology, we have fine-tuned not only sort of the dose of radiation, but our ability to shape the radiation beam or manipulate the energy of the photons that we use, or increase or decrease the dose rate. And so now radiation therapy is just incredibly precise, submillimetric precision and accuracy. For example, when we're treating in the brain, sometimes patients who have lung cancer develop cancer that goes to the brain. It's called developing brain metastases. And so with radiation technology now, we have the ability to treat 20 or more very small brain metastases simultaneously in a single treatment and spare all the normal tissue in the brain. So we can kill those cancer spots, 90+% chance that those spots never come back, and the patients typically do great. Now when we're treating cancer in the brain, it's easy because it's kind of sitting still for us. When we're treating in the lung, it's not sitting still. You know, the tumor's moving as the patient breathes and can move up and down, it can move forward and backwards, kind of depends on where it is. And so now radiation technology it has evolved such that we can actually track the tumor's motion during the respiratory cycle. We can have fiducials placed that track the tumor even in real time while we're treating. And the treatment table can move in 6 degrees of freedom to adjust the patient to the right position. So radiation therapy now is incredibly precise. We create models of the patient's tumor that are not 3-dimensional but 4-dimensional, you know, through time. And so we factor all that in when we're treating lung cancer. The technology is really amazing. Side effects kind of come with cancer treatment, unfortunately, and they're very dependent on chemotherapy or radiation and kind of what agents are used or where we're treating. For chemotherapy, the chemotherapy agents go all throughout the body, so you can have sort of general side effects such as fatigue or nausea or GI upset. There can be some impact on the immune system, such as low blood counts and immunosuppression and that sort of thing. Patients can lose their hair. It really depends on the situation. And there are always things we can do to help manage that and treat that and improve those side effects and get the patients through treatment. For radiation therapy, it's different. Radiation can always cause some mild or moderate fatigue, but the other side effects kind of depend on where we're targeting the radiation beams, where we're treating the cancer. So when radiation kills cancer, we can cause inflammatory like reactions or side effects. And so if we're treating in the lung, sometimes the lung near the tumor can get a little irritated. Patients can have a cough or shortness of breath. If we're treating in the GI system, in the throat, we can cause pain with swallowing or difficulty swallowing or nausea or diarrhea if we're treating in the GI tract. So when you're getting chemotherapy and radiation treatment, your cancer doctors are seeing you regularly. In the radiation department, I see patients at least once a week, and our therapists and nurses are seeing them every day to manage these side effects and make sure we're treating them. And there are always things we can do to mitigate what's going on and have a successful treatment. The treatment plan for a specific patient is very highly individualized and customized. So first of all, we look at the type of cancer, the location of the cancer, the stage of the cancer, which is kind of a measure of how advanced or localized it is. Often patients are discussed at our multidisciplinary tumor board, which is a meeting that we have every week with all sorts of doctors, radiologists, pathologists, medical oncologists, surgeons, radiation oncologists, a huge team of people who get together and kind of agree on the best way forward or the recommended course of therapy for a patient. And I should say that we make recommendations, but ultimately it's up to the patient to determine their own course. They make the decisions. Our goal is really just to help them make an educated decision about their care. So we determine the sort of best way forward in terms of their cancer and the stage based on national guidelines and scientific data. And then when we actually get into the details of treating that patient's tumor, like I was saying before, the radiation therapy, we incorporate all sorts of diagnostic scans, PET scans, MRIs, CT scans, and we create this model of their tumor that is based on their exact tumor, the shape, the distance, the contours of their tumor and their lymph node involvement. And so it's not only just sort of individualized, but it's very specifically customized to that patient's exact tumor and disease burden. So.